Thanks so much for the introduction and for inviting me to speak to you today about this topic that I think is very important and have spent a lot of time thinking about. So I wanted to talk to you today about the gut microbiome and non-traditional treatments for C. difficile infection. And I wanted to take this moment to kind of reflect on where we've come from in the treatment and management of C. difficile infection and where we are now and kind of where I think we're headed. These are my disclosures. Some of these companies will be discussed in this talk, and I will do my best to present a fair overview of their data. So as I mentioned, I think we're in an inflection point in the care of patients with C. difficile infection. The first way that has manifested is in the epidemiology of the disease. So many of you who took care of patients in the 2000s may remember the epidemic, where in the 90s, this was an infection that was more of a nuisance rather than a major healthcare threat. And that quickly changed with the outbreaks that happened and some of the major severe infections and mortality that we were noticing in patients. That's not the case as much anymore. And the epidemiology has shifted so that this is worldwide and is an epidemic worldwide. There's still hundreds of thousands of people every year that get this. The severity is a little bit less, but now we're having a problem with recurrence, where that's driving a lot of the cost in healthcare utilization and a lot of the morbidity. We're also at an inflection point with diagnosis. Many of you may recall how we had very insensitive tests, and we used to have to send 3 of them before we could even say someone was negative for C. diff. Whereas now we're on the other side of this, where we have very exquisitely sensitive tests, and sometimes we're stuck trying to decide if this is colonization or real disease. And many people around the country who are in charge of infection prevention programs are struggling with how to best capture this, but also not get dinged by the National Health Safety Network for inappropriately high rates due to their testing modality. We also have monoclonal antibodies available now, which wasn't even the case just 5 years ago. And now we have both live biotherapeutics in development and available, and fecal transplant as a modality. So with that little bit of reflection done, let's review the agenda. So I want to talk about where we are right now, and in particular focus on fecal transplant. I also want to spend the second half of the talk about probiotics, where we are with that field. And in my opinion, I think there's been exciting developments that have happened, but still a long ways before we can make a lot of progress there. And then I'll give you my opinions and thoughts about future directions. So what is the current state of the field? And I'll start by just reviewing the biology. So C. difficile infection is caused by a gram-positive anaerobic spore-forming life cycle and the disease. It's gram-positive, so that informs what kinds of agents we would use to treat it with, such as vancomycin. It's an anaerobe, so that makes it hard to cultivate in typical microbiology laboratory settings, and you require special media and anaerobic chambers to do it. And it's a spore-forming bacillus, and the spores are very hardy and difficult to kill, and that informs the treatment and the spread of this in hospitals and outside of healthcare settings. The syndrome itself varies, and we've increasingly recognized now over the last decade that there is this asymptomatic carriage or colonization state that many patients can have. Even after illness, some patients just have a mild course that could be even self-limited, whereas others, as we could experience very severe disease, and unfortunately, people still die from this every year. I mentioned the burden. Here's some actual numbers through 2017, which is when the official numbers are most recently reported. And although you see a slight decline in some of the numbers, overall, it's still clear that there's hundreds of thousands of people a year that get this in the United States. Even after initial cure, a decent fraction, somewhere between 15 and 25%, will recur. And that drives a lot of the cost, where this is now a major burden on the U.S. healthcare system. And recurrent C. diff in particular is a big problem. And that's of germane interest to today's topic, where we're talking about fecal transplant, because that's often what we're using to treat this scenario. On average, there's a large number of prescriptions for vancomycin and stool tests for each person with recurrent C. diff. Because the people who recur are often elderly with comorbidities and frailty, when they recur, they may need to be hospitalized to make it through that recurrence. Some of them have a severe course during that recurrence that requires colectomy. So all of these things in aggregate drive the cost up quite a bit, and is still a major problem. All right, so before we talk about where we are with treatment right now, I'll review the guidelines very briefly and then talk about fecal transplant, the main thrust of today's topic. I did want to spend a little bit of time reviewing the pathophysiology of this because I think it informs a lot of what we're going to talk about going forward. So hopefully you can see my mouse cursor, but if so, if not, I'm highlighting this normal microbiome depicted in the upper left corner here. And that normal microbiome has some features, lots of different taxa, and the composition of the taxa is different than a disrupted microbiome. And overall, it's a diverse, healthy community. And something happens to disrupt that. And that something is usually antibiotics, which can lead to loss of colonization resistance. That's the arrow now going to the susceptible microbiome, more in the upper right. And the features there, you'll notice visually, are depicted as just a loss of certain taxa, new taxa showing up that weren't there as much before, and overall lower diversity. So this is a susceptible, vulnerable period. And if during that period you're exposed to spores, then those spores can enter your digestive tract. They can germinate and grow into vegetative C. difficile, which then can make toxin and cause disease. And that's this pathway here with this person in red, who then gets treated with the usual antibiotics. And then notice I didn't color this person green after treatment because they kind of aren't completely recovered yet. And thankfully, most people in this situation will then eventually go on to recover and restore their microbiome function so they won't be susceptible to C. diff anymore. We call that restoration of colonization resistance. But a good fraction of people will end up in this cycle that sometimes is only broken through a fecal transplant. It's also interesting to note that many people, even after infection, can clear this or end up in an asymptomatically colonized state rather than infected and symptomatic. It's not entirely clear what drives these processes. But this is one scenario where probiotics have been thought about, where even during this vulnerable period, we manipulate the microbiome to prevent that episode of C. diff from happening. So probiotics, I'll talk about at the end of the talk. That's going to be more evidence-based in terms of disease initiation. Fecal transplant I'll talk about soon, and that's more something we have evidence for in preventing recurrence. Before talking about fecal transplant, just quickly wanted to review the state of current treatment evidence for C. difficile. So our guidelines were getting kind of old and creaky until 2017 to 2018 when they were finally updated. And the update basically removed metronidazole as a preferred option. Before this disease, that was always a scenario where it was recognized that vancomycin was superior. But based on some studies and some data that came out of a trial that I'll show on the next slide, that convinced the authors of the guideline that even for mild disease, that metronidazole was inferior to either vancomycin or fidaxomicin. And that's what drove this recommendation. The other part that was new was fidaxomicin was a new drug, so it officially made its way into the recommendations at this stage. And I won't go through all the doses here. You can read them on the screen. This is the evidence that drove elimination from metronidazole as a preferred agent for mild to moderate C. diff as well. It was a randomized controlled trial, and the purported purpose of the trial was actually to look at tolevomir as a potential treatment. That was a big failure. Certainly should not be using this toxin binder alone to treat C. diff. But in the secondary analysis of this study, they actually saw that these two studies rather, they actually saw that even in the context of mild C. diff, that vancomycin was superior to metronidazole just for initial cure. This also was borne out in recurrence, and this is not the only data to show this. It's been since demonstrated in other studies as well, which I'll go through in a few slides. This also shows how for recurrent C. difficile, fidaxomicin actually ended up being superior to vancomycin in the initial trial data, and was given that indication on the FDA guidance. If you have a more severe course of C. diff, I'm not going to cover this in too much detail, but here definitely don't want to be using metronidazole, but both vancomycin and fidaxomicin are options. And if you have complicated C. diff, that's when you bring out the high dose vancomycin, IV metronidazole, and then you also give it by an enema if they have an ileus and you're just worried about enough effective drug getting down to the site of infection. And it's worth pointing out that this is really the only place where IV metronidazole has any helpful benefit or utility in treating C. diff. I'm going to skip some of these slides in the interest of time, but it's worth noting that the other thing that we've kind of recognized over the past decade is that it's worth getting our surgical colleagues involved as early as possible rather than late. They have an interesting thought process they walk through that can be really helpful. And then notably, they now can offer patients something other than total colectomy, which is this loop ileostomy and anterograde vancomycin enemas through the ostomy, which has been shown in some studies to be a colectomy sparing procedure and is life-saving as well. All right, now recurrent C. diff. This is where we start thinking about the main topic today, microbiome manipulation. So the guidelines that were revised suggested fidaxomicin or vancomycin would be good options here, or a vancomycin taper. But in particular, if they already did vancomycin before, you want to be either doing a taper or going straight to fidaxomicin. And this is for a first recurrence. If they keep recurring, though, that's when the guidelines actually gave you 4 different options and didn't really promote one over the other. But this is the first guideline, at least in the US, where FMT officially makes it in here as a recommended modality for patients with multiply recurrent C. diff. And that was several years ago. Studies continued to happen on C. difficile, including FMT studies, including more studies on fidaxomicin. And then we also had a monoclonal antibody that was released. So the guideline committee didn't do a full revision of the guideline, but did a focused, what they called a PICO update, a patient intervention comparison outcome update, where they asked 3 questions. So this was the first question. So in patients with an initial C. diff infection, should you use fidax rather than vanc? And they actually came down after reviewing additional evidence, including additional trial data that I'm not going to show in detail today because it's not the point of today's talk, that actually they were willing to say that fidaxomicin was superior to vancomycin even for initial cure. However, there's this conditional statement, largely driven by the fact that fidaxomicin is still very hard to access for many patients due to availability and cost, saying that this is something that they understand it could be a problem. So vanc is still an acceptable alternative. They're not saying it's unacceptable, but they do prefer fidaxomicin over that. The other question they asked is whether, same question, but in recurrent C. difficile, and they came down with the same sort of answer. Here, however, they do give some suggestions about where about other agents, and again, it's the same 4 bullets that we saw in the previous slide. And then this is some of the data that led to those revised recommendations. But in part, this is also a new treatment modality, treatment regimen of using fidaxomicin, not over the course of 10 days, which is the normal course, but over the course of 25 days. And here's a regimen here and there's at least some study data suggesting this might be even more efficacious than just doing the standard course. And then lastly, bezlotoxumab is a monoclonal antibody that showed some efficacy and was FDA approved as an adjunct at the onset of C. difficile infection to reduce subsequent recurrent C. diff. Again, the committee recognized you can't probably give this extremely expensive and invasive treatment in every single patient who gets C. diff. So there's some suggestions here that they have on how to prioritize who might benefit the most from this. All right. And here's the trial data leading to the approval of bezlotoxumab. Again, I'm going to move on because what I'm really interested in talking about today is more about fecal transplant. So the first clue that we had that the gut microbiome might be a good therapeutic target here is based on this data done by Vincent Young, since I don't have the reference here, back in 2007, where they profiled the microbiome of a cohort of patients, a small case series really of patients, some of whom were controls, some of whom had C. diff but then didn't recur, and others who had C. diff and had a recurrence. And it was the patients who went on to continue to have a recurrence compared to the controls or the ones who didn't recur that had the lowest diversity, the lowest healthiness of their microbiome. And before we get to fecal transplant, people tried all kinds of things, including dietary manipulation. And this is a strategy that, at least in a case series, actually had some pretty decent success. This is done by Johann Bakken. Oh, I'm sorry. Former IDSA president Johann Bakken, with 25 patients, all of whom were cured just by continuing a vancomycin taper, as has been done before with them, but then adding this probiotic yogurt, not a probiotic, but this yogurt drink to the regimen. All right, now what about stool transplant? Well, it's worth considering what is stool, and it's a lot of things. We call it microbiota transplant, and it's in the name, but there's a lot of things other than microbes. There's water and electrolytes, there's nutrients, there's undigested food, there is the microbes themselves, but also undigested pharmaceuticals. And it's important to think about definitions here with that respect. When I say microbiota, I'm only talking about the organisms, but when I say microbiome, it's actually, I'm using ohm, not in the omics sense, but in bio, as in the ecology sense, which is the sum total of the environment and the organisms that are in that environment inhabiting it. Dysbiosis, it's derangement in the microbiome. Now, before anyone calls me out, that I agree, that is not a specific definition. At least in the C. diff world, I use an operational definition, which is colonization resistance, meaning if you challenge them with spores and they can be colonized, then they have dysbiosis. And then the metabolome, there's lots of things that we've learned about how important the metabolomes of these patients are in the therapeutic effect. And I'll show some data about that shortly. There's also worth noting that it's not just bacteria. There's archaea, fungi, viruses, and protozoa in our gut. So all this is to say that I'm going to be showing some data and showing some products and the evidence behind them, but we really don't at a fundamental level understand what is happening here. And even though I'm going to show you data showing how fecal transplant is efficacious, we actually don't fully understand at a fundamental level how it works. All right, so with that in mind, I should note that right now, FDA has allowed individual practitioners to do fecal transplant, either with directed donors or with stool banks, but only for C. difficile that is not recurrent or not responding to traditional treatments. Otherwise, you need to get an IND and do it as part of a study for any other condition. That guidance came out over a decade ago now and prompted lots of people to start doing this treatment. And some people were giving it via enema, some people were giving it via colonoscopy, and preparing it and giving it through the ports, or preparing pills. The first randomized controlled trial, though, was in 2013. And this is a study that actually, it's a landmark study, and it ended early. Now, often when you hear that a study ended early, you're worried about, well, maybe it was because of some adverse events, or maybe it didn't work, so they made them stop. In this case, it actually ended early because the interim analysis looked at these data and said, you know what, this is so big of a difference, this 81% versus 30%. We think it's unethical to keep doing this arm and even offering this to the patients. And oh, by the way, not only is that unethical, you need to go back to these patients that got the inferior treatment and offer them the fecal transplant. So that's actually what this arm is. It was not randomized. They went back and did the FMT in people who didn't get it the first time around and had an even higher cure rate. However, if you keep looking at the data, people have continued to study this. There have been 37 studies, 7 RCTs and case series, and it continued to look like a really effective modality. And so that has led FMT to really become central in the management of these patients with multiply recurrent C. diff. However, many of us who continue to follow the literature were somewhat perplexed by this study, where this group actually filtered all their stool so that there were no microbes in the filtrates. These were sterile fecal filtrates, confirmed by culture. And then they did a case series where they treated these patients. I'm sorry. Let me take that back. That study of sterile fecal filtrates did happen. I'll just finish the thought. That's not what's on this slide. My apologies. The study of sterile fecal filtrates did happen, and those patients in the case series actually did get better. So that's one point that was a little bit unusual. Remember how I said we don't know how this works? Turns out we don't actually even know if the microbes are essential. If you can give people sterile fecal filtrates and still have the therapeutic effect, then maybe we should stop calling it fecal microbiota transplantation, because that one didn't even have microbiota. This study was even more perplexing, where it was a full spectrum fecal transplant. They took stool from donors and gave the full stool to these recipients. But what's weird is it only worked at one site, meaning these people in New York, the placebo arm, where they just got their own stool given back to them, they were all cured too. And what's different about these two sites is in this site, the patients were waiting for the treatment for months and on vancomycin for a lot of that time period. So one has to wonder if you just stopped their vancomycin and didn't even give them a fecal transplant, if they would have gotten better. So this was really weird to see that placebo stool was working just as well as non-placebo stool. And when you look at the trial data a little bit more closely than I did a previous 2 slides ago, the plot thickens, where if you just look at all of the RCTs, sure, it looks like they're nearly 80% effective. But if you split it into RCTs that were done with really rigorous methodology, including blinds and control groups, you see there's a discrepancy where if you look at open label, sure, it looks great, but then the efficacy drops into the low 70s for the rigorous studies. So with that in mind, let's review the data of the pharmaceutical grade approaches to developing fecal transplant that have now become available, in addition to just the stool banks and directed donors that we were doing before. And it's worth noting that there's 3 different approaches. Broadly speaking, there's the same approach as before with the stool banks, but now pharmaceutical grade, which is just taking stool, full spectrum stool, and giving it back into a patient. There's the modified version of that series takes, where they treat the stool with ethanol, so that you're just taking the spore forming fraction. Again, spores are not going to be killed by ethanol. They can make it through that process, but pretty much everything else dies. And then there's the defined consortia, where you're actually taking known strains, cultivating those, and then bringing those forward for treatment. This is a chart just showing what the status is right now of those. RBX 2660 was just approved about a month ago. And right now, it's in the process of becoming made available, and people are starting to use it around the country. But since it was just approved, I actually don't know of anyone who's done it in their patients just yet. Same with Series 109. I think that was just approved a few weeks ago, actually, so even more recently. So I don't know yet about the availability, but these 2 products are approved and going to be on the market or are already on the market right now. So these are possibilities. CP101 phase 2 trial data were published. The company announced in January they were putting phase 3 plans on hold. So I don't know what the status of that product is just yet. That's a little bit in limbo. And then VE303 went into phase 2, and we don't have any data past that just yet. I will very quickly review the data on these studies. All right, so in the interest of time, I'm not going to go through all these trial data. The slides were shared with you, so you have them. I'm going to skip through this, wrap up fecal transplant, and spend the remaining 20 minutes to talk about probiotics. All right? But it's worth noting that all of these trials showed successful data. They all had very similar time points. The differences among them, when you do review the data yourself, are just on these different parameters. Again, in the interest of time, let me skip the trial data details themselves and go to my punchline, which is that overall, I think the treatment recommendations around C. diff have shifted in the past decade. The focus now is not just on initial cure, but on preventing recurrence. And that fecal transplant is one of several modalities used in treating initial or recurrent C. diff, but there's questions around the efficacy and regulatory issues that still remain. We now have 2 approved products, but there's still questions about how available these will be, where they're going to be priced, and exactly where they're going to sit in terms of the protocols and roles that they have in management. But let me move on to probiotics, and hopefully end a little bit early to take some questions if possible. So yeah, FMT is great, but as we've talked about, there is some concern about possible infection risk, and now we worry about SARS-CoV-2 in addition to MDROs and other things. Even the FDA-approved products, there's lot-to-lot and donor-to-donor variation in the product itself. They're not cultivated from individual strains. We still don't know why this works and what the long-term effects are. And there's maybe some issues around tolerability for some patients. And then outside of C. diff, who knows if they're effective? So far, the trial data are really not encouraging for a lot of them. So it's led to people asking about probiotics. Can we design a treatment to manipulate the microbiome rather than just taking stool from a donor in an untargeted fashion and giving it and hoping it works? So one, I think, is definitions. And so the FDA doesn't like probiotic anymore. That's still a term used in a lot of people. So I'm still going to use that term, but you should know that they prefer live biotherapeutic. But ultimately, the definition is the same, which is a live microorganism or set of microorganisms that, when given in adequate amounts, confer a health benefit on the host. And, you know, that definition is a little bit hard to apply, but, you know, whether bacteriophages count or not, most people would consider that something different than a typical probiotic. I think it does apply to defined microbial communities, but I would say, and many people have now come and agreed that things like fermented food, yogurt, undefined consortia, fecal transplant, that is not a probiotic. When people say probiotic or live biotherapeutic, they're talking about things that have been demonstrated to be efficacious in properly controlled studies, and that they are known, defined strains, and to keep live cultures and other undefined consortia outside of the probiotic framework. And then real quick, you might also hear about prebiotics and synbiotics. Prebiotics are undigestible substances that the microbes can digest, and the synbiotic is when you take advantage of that and just give both together. There are different ways we can think about using probiotics in the treatment of C. difficile, both in primary prophylaxis or secondary prophylaxis to prevent the episode, and then also treatment as an adjunct given during the episode. All right, so how do these even work? And is it even feasible to think about using these? And, you know, the first step is, do they make it down to the gut if you give them by mouth? And the answer is yes. This has been studied many times now. These strains are detectable in feces or cultivatable from feces. Sometimes you can detect them in extraintestinal sites. That's not desirable, but that's a safety thing to keep in mind, that some at-risk patients can get bacteremic or even endocarditis from these. They can certainly make it past the low pH of the intestine in the case of L. acidophilus. That's where the name comes from, actually. And many of these are resistant to the antibiotics. So I've had patients ask me, hey, I'm taking vancomycin for my C. diff. Does it make sense to take this strain? And it's like, yeah, this is resistant to vancomycin. So that's why we chose that one. And this is some evidence to show some of the claims I made on the previous slide, but it is important to note that not every subject who took a probiotic did have it end up in their stool. So there may, again, this is getting to the point of understanding the microbiome much more as being important going forward in management of these patients, that even if we find a probiotic that is effective in some people, it may not be in others. And so there's this opportunity for personalized medicine that needs to maybe go forward. All right, so how could probiotics affect C. diff? You know, so they can make it down to the gut and pass the acid barrier, great. But how would they actually work? What are the mechanisms? And so these are some of the mechanisms that people have pursued. Certain probiotic strains could compete for nutrients with C. difficile and as a niche exclusion, drive it out. Some of them interfere with the metabolism of bile acids. And secondary bile acids are inhibitory to C. difficile. And so if you give probiotics that can facilitate this conversion, that may be beneficial. It's worth pointing out that we don't make secondary bile acids. Our human enzymes only make conjugated primary bile acids. We are completely reliant on microbes in our gut to create the secondary bile acids. And one of the things that's lost in C. difficile infection and after antibiotic exposure is this metabolic function. They also make direct antibacterial compounds. Reuteri and bacteriocin can kill C. diff, and so some probiotic strains do that. Other ones more indirectly inhibit the downstream effects of C. difficile toxin production, as Saccharomyces boulardii and Lactobacillus kefir can do that by producing proteases that can chew up the C. diff toxin. Here's some non-specific effects too. They can induce mucin production, alter the local pH, cause inflammation, and increase IgA production, all of which can be beneficial. All right, but do they work for C. diff? You know, the proof is in the pudding. And unfortunately, we don't have a good definitive study to answer this, and the meta-analyses are all limited by these heterogeneous considerations. So again, I'm going to move to the meta-analysis data to show that if you look, I actually do believe that probiotics have a future in the treatment of C. difficile infection. There's a signal among all the noise here. The problem is I can't turn this signal into a specific recommendation for a patient because I don't know what strain to tell them to use. All of these use different strains or combinations of strains. They also use different doses, even if it was the same strain. And because these are food additives, they're not regulated as drugs by the FDA. So there's a little bit of trepidation about what the patient's even getting when they take it. And I think that is one of the reasons that we're not using these more often and that they're not recommended in the guidelines, even in the revised guidelines, despite some of the data that I showed you. There's also a concern about maybe that they're not safe. They're generally regarded as safe, but people can have lots of less severe side effects, but also severe and potentially fatal side effects. There was this one study that showed acute increased mortality when used as an adjunct for acute pancreatitis. And then most trials excluded a lot of the populations where we might have concerns about these safety signals, such as those who are immunocompromised, IBD, and ICU patients. So it's hard to generalize findings about safety to those patients. The other thing that's worth noting, as I mentioned, is the strain specificity, and this has been formally studied. And whether you're talking about using the same bacteria effective in one condition for others, or looking at a condition where one strain has been effective and looking at other strains for that condition, it really does matter that whatever effect you're seeing, if it's beneficial, it is both strain and disease specific. And so that's one of the challenges here. And again, this is saying a lot of the same thing, is it's hard to make a specific recommendation. All right. So that's all the Debbie Downer stuff that I presented. So fine, what is actually being done? And why do I have some optimism about the future of this field? And the reason is because people are now no longer just pulling things off the shelf and trying them and seeing if they work, which is really what all the literature and that meta-analysis did that I showed you. They're going back to the drawing board and saying, what do we understand now about the pathophysiology of C. difficile? And how can we design a probiotic to take advantage of that? So one tactic is to focus on the bile acids, as we talked about. Secondary bile acids are really important in suppressing C. difficile infection. And our gut microbiome makes these. We don't. So you can imagine that it has been implicated in the recurrence of C. difficile. And again, without going into the data in detail, this is a study that we did showing that people who successfully get an FMT do so because they restored this function. And people are now finally starting to do the basic mechanistic studies that are needed before you design the human studies. And here is one where in this mouse model of C. difficile infection, this C. Sinden strain, which was chosen because of this ability to convert primary to secondary bile acids, did attenuate C. diff and actually prevented mortality in these mice. The other tactic that people have taken is to capitalize on the antibacterial effects of some of these strains, such as the ones that produce bacteriocins. Here's a study looking at Lactobacillus reuteri, which makes Reuterin from glycerol. And again, without walking through this really nice set of experiments in this paper, they demonstrated that this is a plausible way forward, that capitalizing on this could have beneficial effects. So this gave me gave me enough to say that this should be trialed in humans. Defined communities is another approach. This is a really interesting study where they actually tried a whole bunch of different mixtures of different taxa that they isolated from mice who were successfully treated by FMT for their C. diff. And most of the combinations didn't work, but then mixture B, which were including these taxa, these specific strains, was the only one that not only treated the mice, but did so and knocked the C. diff down to almost undetectable levels in a persistent way. So this is a classic example of reductionist science where I think they tried 10 different cocktails in the study. This is the one that worked. So that's the pathway forward, but we just started. You might notice many of these studies are just new in the past decade. So as you may know, it's usually 20 years before we move from basic science literature to human interventional trials in an FDA-approved product. So it's worth just pausing a little bit to see if this approach is something that's tractable and has the potential to work. And I'll just mention that we do have one success story. Now, this is a different condition, but this is the idea of using a symbiotic to prevent neonatal sepsis. This is Lactobacillus plantarum. They first did a study over 20 years ago showing that it was immunomodulatory in cell cultures, that it blocked the adherence and translocation into the bloodstream from bacteria in the lumen. If you gave it with fructooligosaccharidoid, it did a better job of colonizing the gut. So that's why they formulated it as a symbiotic and not just a probiotic. And here's the punchline. This is a randomized controlled trial in nearly 5,000 infants. A really hard to do a trial, especially in the developing world, in India, where they did this. But this trial showed that there was a number needed to treat of only 27 babies to prevent a case of mortality and sepsis. And by the way, this costs $1 a day to do because this is an incredibly cheap probiotic. So with that, I think I'll pivot to my future directions and conclusion that I think there is some promise here in the future of probiotic design for C. difficile infection and probably other conditions, but we're not going to get lucky. We can't just take stool and give it to patients and expect it to work. We can't just pull things off the shelf at Whole Foods and expect it to work. I think if we are going to move forward with these designer probiotics and not just fecal transplant, we got to do so in a way that's mechanistic, traditional reductionist science, and probably complementary strains, not just one strain, using these mechanisms that we now know, again, revisiting our pathophysiology of how C. diff works, are the pathway forward. So in conclusion, I think probiotics are safe and well tolerated. Regulation of supplements impedes deployment because you don't know what you're buying when you get it off the shelf sometimes. The clinical data are heterogeneous, impeding progress, and that we need clinical trials. And we're just now starting to get to the place where we have some candidates that we can test in humans. So with that, I will pause here. This is not a faculty meeting, so please do ask questions.
If anyone has questions, go ahead and come forward to the mics on either side. I have a question. Since you skipped over all the data on the new products, where do you see these fitting in relation to the traditional fecal transplants that we've done through, often through colonoscopy? Where do you think these new agents will fall, knowing that they'll probably be priced somewhere at least comparable, I'm guessing?
Yeah. So in terms of the two products that are currently FDA approved, the Rebiotics product and the Series product, they both show really good efficacy. It's online with all the trial data for stool transplant that have been done before. So I don't think it's really an efficacious issue. You wouldn't be picking one over the other because it's better in terms of overall efficacy, in my opinion. I think that's not going to drive this. Like many things in the U.S. healthcare system, what's going to drive what you use is what's available, what insurance is going to cover, how they price it. And then maybe some patient considerations. Some people may not be able to swallow pills due to GERD or dysphagia, and maybe the enema is a good choice there. Maybe they can't do a colonoscopy, and maybe the pills are a better choice in some people. I think that's probably what's going to drive this more than any of the actual trial data.
All right, very good. Well, thank you for joining us, Dr. Rao. We really appreciate your talk.